So good day, dear colleagues. It's a pleasure for us to welcome you together with Ashish Kamat from MD Anderson Cancer Center in Texas. I'm Morgan Roupré, ESOU chairman of the section of oncourology of the EAU. And we are recording today a lecture dedicated to the future of immunotherapy in the field of localized disease in bladder cancer. Thank you, Ashish, for accepting the invitation, and we'll discuss with you right after your presentation.
Thank you so much for that invitation, Morgan. It's my pleasure and privilege to always join you guys and participate in these very exciting discussions. There's a lot of activity going on when it comes to immune checkpoint inhibitors across the field of oncology, which obviously everybody listening and viewing knows. But what many people may not have realized, because it's almost come like a snowball effect, is the impact of this in earlier stages of the disease when it comes to bladder cancer. And I put this timeline pictorial up just as an example of what's happened. So if you look at all the developments that occurred, these are all in the advanced stages of bladder cancer, metastatic disease, et cetera, culminating with the approval of all the IO agents in 2016, 2017 in the US at least. But if you look at non-muscle invasive bladder cancer, we really only had 2 drugs that were approved that are of any use for bladder cancer in the earlier stages. One was BCG back in 1990, and then valrubicin in 1998. And then lo and behold, in 2020, in this crazy year, pembrolizumab was approved on January 8th by the FDA. It's important to recognize, though, when we talk about immunotherapy, that BCG is the original cancer immunotherapy for cancer in general. And if you look at the efficacy results with immunotherapy across the board, really nothing beats BCG with BCG's success story in non-muscle invasive bladder cancer. And in fact, when there is no shortage of BCG, there is a demand of about 1.2 million doses of BCG annually across the globe. But BCG doesn't work for everybody. And at 1 year, roughly 30% of patients will have tumors that recur despite BCG therapy. And at 2 to 3 years, it's roughly 40%. So the success rate is 60%, and that's in relatively modern series as well. But when you look at the classification of BCG failure, essentially this was very confusing for a very long time. People called BCG failures as BCG refractory disease, where you had persistent high-grade disease at 6 months despite adequate BCG. Then it was called BCG relapsing, where there was recurrence of high-grade disease after a disease-free interval. And then there was BCG intolerant. And trials were designed around these 3 first categories. But it was very confusing, and it was hard for regulatory agencies, PIs, investigators, us as readers of all these trials to make much sense of what was going on. So in about 2014, 2015, the FDA approached certain groups, the International Bladder Cancer Group and the GU-ASCO group, and asked us to come up with a definition of BCG unresponsive disease. And the definition essentially, and I'll go over this a little bit more detail, was to combine certain subsets of the BCG refractory and relapsing population to come up with a category of patients where any more BCG is futile, and hence these patients must be looked at either as radical cystectomy candidates or candidates for a clinical trial. So these are the 2 groups that came together. This is just the publication dates and articles that were published. But the FDA approved this as their guidance document in 2018. And essentially, this is what led to the explosion of clinical trials in this arena. This is just a snapshot put together by Noah Hahn of the various immuno-oncology and other trials that came out after the evolution of the BCG unresponsive disease. And I'll talk briefly just about a few of them that pertain to immuno-oncology, which is a topic of our discussion today. Now, if you look at the mechanism of action of BCG, it clearly involves a multitude of pathways within the immune system, but the PD-1, PD-L1 axis is very, very active. So it was logical to then take that to the next step and look at patients who have not responded to BCG and study them with the checkpoint inhibitors. And Keynote 57, which is pembrolizumab trial NCT02625961, looked at this as a single-arm open-label phase 2 study. And the cohort that essentially I'll talk to you about today is the one that we presented at the FDA in December of 2019, looking at the CIS patients with or without papillary disease. The reason that we presented this and the reason that the FDA looks at patients with CIS, as the urologists in the audience know, is because with CIS, we still have disease present in the bladder. So we can actually look at the effect of a drug in a single-arm study and look for a complete response. If you look at the papillary-only disease, those patients have tumors completely resected by the surgeon. So you start out with no disease, and then you can't really control for recurrence based on the expertise of the urologist to use a blue light or other such thing. So in the CIS-only patients, the patients underwent treatment with pembrolizumab. At that time, the regimen was 200 every 3 weeks, and the patient was followed as per normal standard of care with cystoscopies, cytologies, and imaging. This is the bottom line patient characteristics from the trial. You can see here that the median age was very similar to what we see in this group of patients. The prior BCG installations was a median of 12. So these patients were heavily pre-treated. It wasn't that they had just come in with the bare minimum BCG. And the distribution of CIS with T1 and with TA was what you would expect again in this patient population. Important to note that most patients refused a radical cystectomy. They were not candidates. They actually refused a radical cystectomy. And this is the bottom line CR rate. At 3 months, the CR rate in these patients was 40.6%. If you look at the Kaplan-Meier distribution of these patients and see the duration of response, you see that these patients had a durable response with a median duration of response at 16.2 months. So not only did you get a response in about 40% of patients, but this response was durable at 16.2 months. And important to recognize, in those patients that ultimately required a radical cystectomy, we did not lose the window of opportunity to cure these patients because the rate of upstaging was less than 10% at 8.3%. And again, this is less than what we see with historic controls. We can't really make definitive conclusions about this because it's not a randomized study, but it's encouraging that we did not lose the window of opportunity to cure these patients. If you look at the swimmer's plot, you can see that most of the responses are achieved early at about 3 months, and it's not like we have to treat these patients for too long a period if they're not going to respond to pembrolizumab. A lot of subgroup analyses is always looked at in these studies, and this was done in this study as well. The bottom line was that there was no clear difference and no clear predictor of response to pembrolizumab. People looked at the PD-L1 status as well, and with the caveat of small tumors and not really being able to analyze it properly, the conclusion really is that it works across the board with very minimal differences between different subsets. The AEs are what you would expect with an IO agent. I'm not going to belabor the point. Just want to highlight that essentially these are AEs that if the urologists in the audience are looking to incorporate this into your practice, you need to be aware of these and get the appropriate training for yourself and your team. So this was approved on January 8, 2020, and is the only approved IO agent for non-muscle-invasive bladder cancer in the United States. Other drugs have been looked at as well. This is the SWOG study led by Peter Black looking at atezo. As you know, this study closed early because of certain closing parameters, including a patient death on the study. But if you look at the primary endpoint at 6 months of a CR of 27% and an unplanned endpoint analysis at 3 months of 42%, it's very similar to what we saw with pembrolizumab, lending credence to the fact that there is mechanistic rationale. Another study that's been developed and is currently ongoing in very early phases is Keynote 676, looking at pembrolizumab in an earlier stage of the disease, right after induction BCG when the patient still has persistent high-grade disease. These patients are randomized to pembro plus BCG or BCG alone, which is standard of care. And clearly, as I showed you earlier, mechanistically, and we can talk about it just during discussions, this is relevant and exciting to see what happens when we have the mature results. Again, IO therapy is moving earlier and earlier. This is a trial that Dr. Rupert, you're leading, the phase 3 study, the Alban study, where BCG and atezo are compared head-to-head with BCG 6 weeks of induction and 1 year of maintenance against BCG plus atezo in an earlier BCG naive setting of patients. So essentially, there's a lot of activity in earlier phases with single arm, single agents. And of course, there's combination. Just another example, I could go on with examples, but this is the study of Nivo plus IDO inhibitor, again, coming earlier into the phase of BCG unresponsive disease, but now combining the Nivo plus or minus IDO inhibitor and then comparing it to Nivo plus BCG. Now, just a little point that I want to make. When we put together the SITC guidelines back in 2017, there was really the multitude of pages and discussion was about BCG, because that was the only immunotherapy for bladder cancer that was really approved, including non-muscle-invasive bladder cancer. And the IO agents really just had 3 pages in there. We're currently developing an updated guideline, and as you might imagine, these have flipped. So the IO agents really are gaining a lot of recognition. But one thing I do want to emphasize is that the adverse reactions that we see with the checkpoint inhibitors are not something that urologists in general are accustomed to seeing in our practices. Common side effects are GI related. They're related to things above the waist per se. So it's really important for us to recognize that these adverse events, while they're relatively easy to manage, you can stop the therapy, give an interval, and start steroids, et cetera, until you get on to the grade 3 and 4 adverse events. They have to be recognized early, because otherwise they can be fatal for our patients. And that's why today, more than ever, we need to recognize that the management of non-muscle invasive bladder cancer has again moved back into the multidisciplinary approach. And we as urologists, because we see these patients and manage them for long periods of time, need to really get the appropriate training and partner with our medical oncologists to provide the best multidisciplinary care for our patients. Thank you very much.
Anyway, as you mentioned, there is a lot in the pipeline in the field of localized disease. It's absolutely interesting because we are facing a disease which is an endocavitary disease. We all know that we have to perform a good TURBT, and it's always the kind of message we want to deliver. We have the bladder wall, and there is a micrometastatic phenomenon. Do you believe that there is a room for a combination of these systemic drugs and endocavitary drugs in the perspective of the future? Because so far, as you mentioned, there is the Alban trial, which is, for instance, ongoing in France, but we deliver the BCG and the atezo because we thought it could make sense to have a systemic treatment and an endocavitary treatment. What is your opinion about that?
I think that is a very relevant question because, I mentioned the upstaging effect with pembrolizumab in these patients, and it was 8.3%, which is lower than what you would normally expect. So there's some rationale behind the hypothesis that we're treating systemic micrometastases with the systemic pembrolizumab. But of course, to get the same effect within the epithelium of the bladder, just looking at the vasculature of the bladder per se, and studies that have been done, there is some concern that it may not be reaching the earlier epithelium in TA disease, for example, and clearly intracavitary. So combining an intravesical agent, whether it's BCG or even chemotherapy, gemcitabine, docetaxel, or gene therapy, with their systemic agent, especially in the very high-risk patients, the T1 patients who are at risk of metastatic disease, even with non-muscle invasive bladder cancer, but we still need to treat the bladder component. I think the combination is certainly what's going to hold the true benefit for our patients.
Alexandra, Thomas, if you have any point you would like to raise? We cannot hear you, Thomas. Alexandra, if you want to...
Yes, no, I think, can you hear me?
Yes, perfectly.
Combination of intravesical treatment and systemic treatment is very important, and let's not forget that I think the first intravesical treatment is TURBT. So we talk a lot about the extent of the importance of TURBT in muscle-invasive patients before giving neoadjuvant chemotherapy as systemic treatment to obtain complete response. I think it's exactly the same question in non-muscle-invasive bladder cancer. We're talking more and more about new drugs, BCG, immunotherapy, and everything. The first treatment remains the endovesical resection that needs to be extensive, as it's the first part of the patient's treatment, and then combined with BCG plus.
You have a very strong point because it's not easy to have a good trial in the field of bladder cancer compared, for instance, to prostate cancer. And in terms of homogeneity of the practice, when it comes to endoscopic surgery, there is no I tend to tell you that the same quality surgery was done in a place or another. So when you have a multi-center trial, it can be also an issue, because of course we are only talking about adjuvant treatments, and that's a point which remains extremely important. Thomas, are you online?
Ashish, can I ask a question?
Okay.
So look, we've done a lot of single-arm trials in the metastatic setting, which have led to rapid approvals. The atezolizumab biomarker positive approval in the frontline cisplatin ineligible is based on 23 patients. And then the randomized trials maybe didn't hold as much promise. Are we making the same mistakes with pembrolizumab in the frontline setting? In that, actually, if you look at the 12-month progression-free survival, even in the responders, the data is not earth-shattering. How many patients do you think we're really helping? And of course, how many are we harming on the other hand? And what's your expectations for these randomized trials?
So, the issue with the patients that are BCG unresponsive disease essentially is that if you look at any drug really, whether it's pembrolizumab or gene therapy, or if you look at Vicinium, which is another antibody drug conjugate that has been studied and presented, the numbers are right at about 20%. And maybe 22, maybe 24%, et cetera, et cetera. And the duration of response is something that's critical in these patients, because what is the goal essentially? In these patients, we're trying to avoid a radical cystectomy. They do have a curative option, radical cystectomy. It's not like they don't have any other option, but the radical cystectomy is morbid enough that the patients are not willing to accept that, which is why I think the point that you make is very, very important. And the way I look at these agents is that if you have an agent, and I'm just talking about pembrolizumab since that's what we're talking about, that you can give for a duration of 3 months and then identify those patients, those 40% that are responding, that then have a potential durable response, that's the subset of patients you're benefiting. The other large majority of patients, 60 to 70% of patients, will not be helped by the drug. But fortunately, in most of these trials, you can pick those patients up in 3 months. And because these patients are still candidates for radical cystectomy, I find that most of these patients, if they've given an agent, pick your agent, drug X, a trial of 3 months, then they're convinced to have a radical cystectomy. And they go on to have the surgery. So I completely agree with you that in the single-arm study, it's really hard to tease those factors out. The best comparative arm is radical cystectomy or best standard of care. And personally, I would like to see a trial where you randomize to best practice at a particular center, but that just has not been successful in the past. So your point is well taken, Tom, but we have to sort of work with our patients and what they want to do.
Can I ask a really quick question? Really quick. So is the atezolizumab data the same as the pembrolizumab data, or can you, obviously you're not allowed to do cross-trial comparisons, but one's FDA approved and one's not. Can you see any difference between the two data sets?
I don't really. I don't see much difference between the two data sets. I actually think that they overlap fairly significantly. The trials are designed a little bit different. Well, because one closed early because of closing rules with AEs of the trial. And they will go up in front of the FDA, but it remains to be seen what the FDA says.
Okay, guys, thank you for this very interesting discussion. I think it's time to close this first part of the ESOU Online. Thank you very much, Ashish, for your presentation.
My pleasure. Thank you.